So Dr. Andrew Braganza will discuss whether you want to perform a trab or a tube in a primary glaucoma.
Good afternoon, everyone. And tube versus trab. By tube, we mean aqueous drainage device. So I've put that there. And we can look at it, and going back in history, we can look at as a primary trab versus tube, which was the oldest study across all glaucomas. And we can look at it as the trab versus tube as first surgery in a primary glaucoma or in a treatment naive primary glaucoma. So our traditional treatment hierarchy is to first try medical, add on laser, then if there's a cataract, do a cataract alone or along with an MIGS, and then you do surgery. And you can do filtering surgery, you can do implants, and you can go on to cyclodestruction, and there are all sorts of combinations of these. And this is what our current flow chart looks like. And if you decide at the first diagnosis whether you're going to do go for medical treatment, then primary filtering surgery or primary tube, it would look something like this, and MIGS would have a role in intervening in at various stages of this. So if we go and revise ourselves in tubes in specific glaucomas, then definitely tube is preferable to trab in neovascular glaucoma, uveitic glaucoma, many other odd kinds of glaucomas like ICE syndrome, aniridia, very often in traumatic glaucomas, very often in pseudophakic glaucomas. But that's not what we are here to discuss. The efficacy of the trab versus tube study, again on these kind of glaucomas, they were all previously operated eyes. They all underwent trab with mitomycin or a Barvelt implant. They both had similar IOP control at 5 years, similar additional medications, and the tube success rate was higher because part of the success was taken as the lack of additional interventions, and there were much more additional interventions after trabeculectomy. Now, if we look at the primary trab versus tube study, and these were all incision surgery naive patients. They did not even have cataract surgery. And their average age at recruitment was about 10 years younger than the trab versus tube study. The IOP control in their results was no different at 5 years. Okay, so it was about 13.4 millimeters actual IOP with the tubes and 13 with the trabs. There were fewer medications in the trab group. So it was 1.3 versus 2.2 with it, which was significantly different. But complications were more in trab, although this did not show statistical significance. There was no difference in the rate of surgical failure as defined in the study at 5 years. But the authors considered that trab was the most successful surgery. So that leaves us completely in the dark again. There have been a few publications by the authors of that study where they have looked at sub-analyses and tried to compare subgroups and see whether you can identify those patients who would benefit more from a trab or benefit more from a tube. And what they found was, what they really studied was, what was the initial IOP at the time of initiating the treatment. Those with a lower pre-op IOP did much better with the trab than with the tube. And this we can expect because really we know that if you would want to achieve a nice, good drop in intraocular pressure, you'll do a trab. Because you can even achieve single-digit pressures depending on what your defined target pressure is with a trab, which you can't do with any other surgery. The higher pre-op IOPs, however, showed slightly better results with the tube. And here I'm talking about their lower IOPs were 21 and below, the middle range of IOPs were 21 to 25, and the higher IOPs they defined as more than or equal to 25. So when you had IOP less than 21, there was significantly less surgical failure with trabeculectomy. When the pre-op IOP was more than 25, there was significantly less surgical failure with the tube, and this is their 5-year results. So what it seems to indicate is that You have some guidelines now for making a choice, but there are many facts to consider, and this is just my own thinking. There's really no major published data on this. There are some glaucomas where a tube is definitely preferred to a trab, and these are the secondary glaucomas. But in the primary glaucomas, the efficacy of the trab and the tube at 5 years is very similar with this study. The safety, okay, more short term complications with the trab, but none of these have been major complications. All have been dealt with. The same amount of 5 year complications are there with both approaches. And the sub analysis suggests that lower intraocular pressures, it's better to do a trab rather than do a tube. And with the higher intraocular pressures, it's the opposite way around. My question is, and what bugs me is, in the event of the failure of the primary tube, okay, you've got this patient who's a primary open angle glaucoma, and you've said, all right, his pressure is 26 or 28 or 30 or whatever it is, and I'm going to do a tube. And you do the tube, and he does well for 4 years, 5 years, but then it starts to fail. What will you add on to this patient? Okay, and I mean, when I say fail, I mean you've used all your maximal medical therapy, everything. But the pressure is still beyond what you have defined as the target pressure. What will you do? Is MIGS an option? No evidence. It may be technically difficult also to do it. And MIGS are not designed for great IOP reduction. SLT may be possible. Should we do a trab on top of the tube? It may be possible. It can be tried depending on the state of the conjunctiva. Can we do another tube? And to my mind, that seems to be the most logical thing to do, because you can stick a tube in anywhere, and you can even put the plate in the inferior quadrants without an increased risk of infection. Unlike with a trab, you have to, have superior trabs. And now we have more sophisticated ways of cyclodestruction, which can be better controlled, better titrated. We have the laser systems, which can be transcleral, micropulse, which again is something which is a bit iffy. And there is the high intensity focused ultrasound, terribly expensive, but pretty effective. So all these are coming in, and we can possibly do that. But in our current state, okay, I would suggest that it's better for us to follow our treatment hierarchy as defined by the conventional wisdom of many glaucoma specialists over several years. I would say do a primary tube with higher IOP levels needing control, and a lot of this depends on the surgeon's own comfort with how, with what approach he uses. Some tubes and trabs will inevitably fail, and we have no evidence on how to proceed with this if we do these as a primary procedure for a newly diagnosed glaucoma. Logic suggests that multiple tubes is possible, multiple trabs may be possible. Trab following a tube also may be possible, but I'm not really sure about that. And controlled titrated cyclodestruction is coming in. Lots of new technologies are coming in, so we need to decide what we want to do. Thank you.
Thank you, Dr. Andrew. We will take the questions at the end of the session. So Dr. Thomas mentioned that the PI will reduce the risk of conversion from PACS to PAC by half. So there is the other half also. So Dr. Ronnie will tell you how lens extraction and laser peripheral iridotomy, fight off against each other in primary angle closure disease.
So good afternoon, and I'll speak about this aspect of angle closure. So basically, what we hope to see after a PI is that the angle opens up widely. And this happens about 75% of the time in PSC and PSCG. Lens extraction also results in a widening of the angle. So both are considered as treatment options in angle closure. And we'll talk about what happens in angle closure disease, specifically in PSC and PSCG. We are not going to talk about acute primary angle closure glaucoma, and we're going to talk about these two conditions. Plato iris can occur in any of those situations, and that gets the other thing that we need to keep in mind. So what is the role of an early lens extraction versus YAG-PI? So Thomas has already showed you this, and this basically says that when you have PACS and you're following them up PSC and following them up, 28.5% progress to PSCG. 1 out 9 eyes progressed in spite of a patent YAG PI, and 7 out 19 eyes progress without a YAG PI. And that was the basis for the decision, that saying that all eyes with PSC should undergo an LPI, which is the guideline that we have been following. So if you have primary angle closure, there are two possibilities. You can either have Sinike with or without raised IOP, or you can have no Sinike but with raised IOP. All eyes undergo LPI. Post LPI, there are again two situations. One, you may have a persistent narrow angle post LPI about 25% of the time, or you may have open angles post LPI. So basically, from our point of view, in these two eyes situations, the problem is solved. We really don't need to do anything else. For these two, maybe there's a physiological basis for lens removal. The same situation appears in primary angle closure glaucoma. Occasionally, of course, you do get apposition persistent in plato iris even after cataract extraction, and that's usually because of the presence of iridociliary cysts. Most of the time, cataract extraction does open up the angle. So this study was done to look at the effectiveness of early lens extraction for the treatment of PSCG. And it's the EAGLE study. So the questions that we have are basically, does it help with angle control? Does it help with IOP? And does it help with disease progression in terms of disc or visual field? And these are the inclusion criteria. So PSCG, you had to be more than 50 years, you had to have a field effect, or you had to have any of these changes on the optic disc. You had to have an IOP of more than 21 millimeters of mercury at least one visit. For primary angle closure, in addition to the narrow angles, you need to have at least one IOP of more than 30 millimeters of mercury. So it wasn't all primary angle closures, it was a highly selected group of primary angle closures. So you had to have 180 degrees or greater of appositional or cynical closure for inclusion. And the results, basically, they looked at two things. They looked at quality of life and they looked at intraocular pressure. Since this study was also funded through the UK, quality of life becomes an important thing for them, because when you're looking at public health, that's an important metric. And the difference in quality of life, and this is on a scale of 0 to 1, the difference was those who had lens extraction were 0.052 points better than those who did not. So 5% difference in the quality of life. In terms of intraocular pressure, a 1.2 millimeter better intraocular pressure control at the end of the thing. So in terms of the baseline characteristics, if you continue the clear lens extraction versus the LPI